Hello and welcome to our phenomenal panel with some amazing women in medicine and surgery. We have a panel today where we'll be talking about GI cancers, and my name is Dr. Shikha Jain. I am a medical oncologist at the University of Illinois in Chicago, and I will be your moderator today. So without further ado, I'd like to spend just a few minutes letting our speakers today give a little introduction and a little bit of information about themselves. So Dr. Soares, can you tell us a little bit about yourself?
Hello, everyone. Thanks for having me. I am Heloisa Soares. I'm a GI medical oncologist at Huntsman Cancer Institute at University of Utah, and I co-lead the GI Research Clinical Trials Group. Thank you for having me.
Dr. Cannon?
Hi, yes, thank you for letting me join you for this today. So I'm Jamie Cannon. I'm a colorectal surgeon at the University of Alabama at Birmingham. I run our colorectal fellowship, and my primary interests are in robotic surgery and colorectal cancer.
Great. And last but not least, Dr. Sanford.
Hi, everyone. My name is Nina Sanford, and I am a GI radiation oncologist at UT Southwestern in Dallas, Texas. Happy to be here.
Great. So we've got a lot to get through. So without further ado, we're going to jump right into our case, and we'll start off with Dr. Soares.
All right, so this is the case that I have for us today. So we have a 32-year-old woman who presented with rectal bleeding and iron deficiency anemia. Initially, when saw her healthcare team, it was felt it was due to hemorrhoids, but the symptoms persisted after 3 months. She returned back to her PCP. A colonoscopy was ordered to show a rectal mass about 3 centimeters from the inner verge. A biopsy was done, of course, and unfortunately came back with a moderated differentiated adenocarcinoma with the MMR stains being intact. She then was referred to a multidisciplinary group and had CTs of chest, abdomen, and pelvis with IV contrast. They really, thankfully, did not show any evidence of metastatic disease. So let's see how the case evolves. So first of all, I think what's important to stop and think about it, would you suspect rectal cancer in a young woman? And as a matter of fact, when we look at some of the publications that have been done in the last years, we see that many times it takes a little bit of time for healthcare providers or for their own patients, if I may, to think about colorectal cancer as a possibility for their symptoms. How many times we have seen that patients that have rectal bleeding are just told that they have hemorrhoids and not to worry about it. We see these things in clinic, unfortunately, more than we wanted. And these are some of the statistics of patients that quoted their experiences. And we can see in the bullet here that, for example, 63% of the participants of the survey had to wait 12 months or so to see the physicians that are dedicated to this sort of symptoms, including colorectal surgeons. So there is a lot of delay in treatment for these patients. Next slide, please. So unfortunately, the incidence of colorectal cancer is actually increasing in patients that are 50 years and younger. You can see here up to 45% increase compared to prior years. Next, please. Again, you can see that is increasing in all sorts of stages of diagnosis, and unfortunately, including in patients that have distant metastasis at the time of diagnosis. Next. Another way to show the data and to make us aware of the increase in patients, and you can see that these patients, unfortunately, even if they're younger than 50, they are being diagnosed in late stages. Next. And we can see here that even patients that are younger than 39 years old can be diagnosed with colorectal cancer. So we really should, as a whole community of healthcare providers, start paying more attention to that. Next. So this is the faces of our patients nowadays. I can, unfortunately, I have many young patients that is more than I ever wanted to have. That are having metastatic colorectal cancer. So just to have an idea, we have more than 17,000 new cases per year, which represents 49 cases per day with a significant amount of deaths. And many of these patients have children, as you can see here. So again, the point of highlighting the importance of thinking about this disease and doing appropriate screening. Next. So can we change the risk factors? Why are we having increase in the incidence of colorectal cancer in younger folks? Well, perhaps we can attribute some of that to obesity, to the dietary issues, including a lot of processed meat consumption, and the decrease of physical activity. Next, please. So perhaps we can start working on strategies to change that. We should control obesity as an epidemic, and try to incentivize patients to be more active as a whole community, including engaging primary care physicians. And this is not only for colorectal cancer. I think we have plenty of evidence from many solid tumors that exercise and obesity can contribute to decreasing the risk. Next. So in summary, we can see that the colorectal population is rapidly shifting to younger, and we support early screening, and we'll touch bases on the guidelines in a second. And we really should, as a community, encourage a healthy lifestyle. Next, please. So finally, to just remind everybody that the guidelines from the U.S. Preventive Task Force came about, and we continue to recommend screening for all the patients that are 50 to 75 years old, but also there's a lot of push to start screening patients at age 45 or even 40 if the patients have a significant family history, and I just want to remind everybody about that. Thank you. Next slide. So just to recap, we have this 32 years old female with rectal bleeding who was found to have this rectal mass at 3 centimeters from the anal verge. Is a moderate differential adenocarcinoma with MSS, and has no evidence of distal disease. So she was referred for a multi-D group discussion. Next slide. So I'll hand it to Dr. Cannon, who's going to talk to us a little bit about local staging, since we know already that this patient doesn't have any evidence of metastatic disease. Thank you.
Very good, thank you. Yes, so she's already had her CT scans of the chest, abdomen, pelvis, which is generally the first place to start, and that's just to rule out stage 4 disease. But then for rectal cancer, we want to get more information about the local tumor itself. And we essentially have 2 options for local staging, and that's endoscopic ultrasound and MRI. Traditionally in the US, endoscopic ultrasound has been done for a long time, and we've just more recently made a move to where more patients are being staged to MRI in the United States. MRI has kind of been the gold standard in Europe for a considerable period of time, but they both have a place in rectal cancer staging. Next slide. So how do we decide which one? Go ahead, next slide. Well, currently in the United States, most patients are getting MRIs of their rectal cancer. And particularly if you're at a nationally accredited center, it is required that all of your patients receive an MRI. And there are definitely some advantages to MRI. However, there are some circumstances where ultrasound can be useful as well. MRI gives you information about the pelvis as a whole. It can give you information about your chances of having tumor going outside what your resection margin will be at the time of surgery. But ultrasound can give you information about earlier tumors as well. Specifically, MRI is not as good at differentiating between a polyp with high-grade dysplasia versus a T1 or a T2 tumor. So ultrasound can give you some more information about those very early stage tumors. However, there are a lot of limitations to ultrasound in that, particularly if the patient has an obstructing mass, you can't get the probe to actually pass in order to be able to conduct the ultrasound. But another advantage of ultrasound can be that if, say, you have a lymph node that you're not sure if it's positive or not, you can see that lymph node on ultrasound, and you can often get a fine needle aspiration to determine if it is actually a metastatic lymph node. And next slide. But there's a lot more information that we can also get from the MRI that's important to have. Today, we have synoptic reports of the MRI, so the radiologist will go through and tell you all of the kind of important details that we need to know. And those include distance to your mesorectal fascia, so that predicts your circumferential resection margin. They can tell you distance from the anal verge, tell you about invasion into other organs, amount of invasion into the mesorectum, and then also invasion into sphincters, which when you're surgical planning is a very important detail. Next. So this is just an example of the level of detail that you can see on an MRI that you're unable to see on an ultrasound. So you see on here, the white arrows are just pointing to the wall of the rectum, and then the green arrows show your mesorectal fascia. And we'll talk about surgery for rectal cancer here shortly, but generally speaking, that is where your plane of resection is going to be, is around your mesorectal fascia. So the MRI can let you know if that planned circumferential resection margin is going to be threatened. Next slide. So local staging, what exactly does that mean? So we stage these tumors T1 through T4, depending on their depth of invasion into the wall of the rectum. So a T1 is going to be growing into the submucosa, where a T2 grows into the muscularis. And then a T3 will grow all the way through the muscularis so that it is reaching your mesorectum. I think it's important to recognize, and one of the ways that MRI can be very helpful is that not all T3 tumors are created equal. So MRI gives us additional information into actual depth of invasion in the mesorectum. So you can have a very small T3 tumor that has just barely gone through the muscularis and has reached the mesorectum. And that's a very different tumor than a big bulky one that is extending to the edges of the mesorectum. And then a T4 tumor is one that is growing into other organs. So, and your most important piece of information in terms of your risk of local recurrence is the likelihood of having a positive circumferential resection margin. And this is one of the areas where MRI is really shines, because again, it can actually measure in millimeters and tell you the distance of the tumor to your mesorectal fascia. Next slide. And this is just showing, so you can see down there on the lower rectum versus the mid rectum and the upper rectum, because the location of these tumors will be managed differently. In the lower rectum, we may be worried about invasion into the sphincters. And in the upper rectum, we may be completely above the anterior peritoneal reflection, and those patients may not necessarily need neoadjuvant treatment. Next slide. And also very important is who actually reviews the MRI. So we have to worry about the quality of the MRI. As I mentioned before, we now have synoptic reports that give all the important information. And then having a radiologist that is trained specifically in rectal cancer MRIs is very important. As you see the data here, you get better sensitivity and specificity if they're reviewed by an expert radiologist with training in rectal cancer as compared to a general radiologist. Next slide. So all of these patients in this day and age really should be being evaluated by a multidisciplinary team, and that team should include an expert radiologist. I know at our institution, we often get reports from outside facilities that are just very generic reports and don't really give us all those details that we need. So having a multidisciplinary team with an expert radiologist, having high quality images, and then reports that really go through the synoptics and provide you with all the information that you need are important in your treatment planning.
I think in summary, we just learned that, they definitely MRI is very important and should be incorporated, but there is a big role for USs as well. And I think I can comment on my institution that MRIs of the rectal is part of our algorithm, and then on a case-to-case, we complement with US.
So I think that's an interesting discussion topic. I'm curious at different institutions if EUS and MRI are utilized differently. I know, similar to what Dr. Soares just said, we also try very hard to use EUS often for initial evaluation, because once a diagnosis is made, we often are able to use EUS for tissue sampling, but then the MRI really gives us a better picture of the depth and the position. So I'm curious as to in other institutions, do you utilize both EUS and MRI, or do you choose one versus the other?
So I think our institution is probably similar to yours as well, that all our patients have to have a baseline MRI for staging. As a radiation oncologist, I also find it very helpful for radiation planning. And then also we get a post-treatment MRI. So we really need that baseline MRI to look for tumor response for patients undergoing neoadjuvant therapy. So I would say all our patients get a baseline MRI. EUS is definitely used quite a bit less. Most of our patients have had biopsies via a colonoscopy. So yeah, MRI for all our patients.
Fantastic.
And I would, at our institution, it's very similar, an MRI for all of our patients. If we think if it's an early cancer and we think the T stage might make a difference in management, then they would get an ultrasound as well. For example, if we're debating whether it's a T1, T2, or in situ disease versus a T1, and we're considering maybe a transanal resection rather than neoadjuvant treatment and a more radical operation, then those patients might get an ultrasound to try and better determine the T stage of an early tumor.
And just to echo one of the earlier points that Dr. Cannon made, it is very important to have an expert radiologist who is used to reading rectal cancers, read the images and interpret the images. And we have a template for sort of how to describe rectal cancer, distance from, rectal junction, threatening mesorectal fascia, number of nodes. And we've had a lot of cases where our read has been different than the outside read.
I think that's really important, especially when we talk about treatment paradigms, when there's such a big difference between how we treat rectal cancers at different stages. I think it's really important to make that point that the staging is very key, and we need to make sure that we have a multidisciplinary approach with these patients. All right, so continuing on.
So this is the MRI of the patient who has a T4N1 tumor, and you can see here the details. So I think we can jump for the next slide and decide how we're going to treat this patient. Dr. Sanford, I'll hand it to you.
Okay, so there are many treatment options for rectal cancer, for locally advanced rectal cancer. A more historic standard established by the German rectal trial in 2004 was giving patients long course chemoradiation, which is about 5 weeks with a radiosensitizing chemotherapy, either 5-FU or capecitabine, followed by surgery, followed by adjuvant chemotherapy. So this was established in 2004. Prior to that, the standard of care was upfront surgery. But since then, there has been really a push for neoadjuvant therapy. And you can see that all of these treatment options around this wheel do not include upfront surgery. Next slide. So I will talk about a study that has really established this treatment paradigm, short course radiation, chemotherapy, and surgery that was presented last year, but has, I think, gained even more traction over the past year. Next slide. So just a little segue. So the role of perioperative chemotherapy in rectal cancer. So the role of chemotherapy in rectal cancer is actually extrapolated from colon cancer trials. So there's no randomized data looking at adjuvant chemotherapy for rectal cancer. However, the guidelines recommend 6 months of chemotherapy, perioperative chemotherapy in locally advanced rectal cancer. And that is split between chemotherapy given with radiation for about 2 months versus plus chemotherapy, multi-agent chemotherapy given without radiation. So 2 months with radiation and then 4 months without, for a total of 6 months. Next slide. So there has also been, I would say, a movement towards giving total neoadjuvant therapy for locally advanced rectal cancer. The pros and cons are listed here. The main advantages are that it ensures delivery of systemic treatment. There is intact tumor vasculature and microenvironment is not disrupted. There's early treatment of micrometastatic disease. It can offer in vivo assessment of tumor sensitivity and it potentially a platform for research as well. And I would also say another pro of it is optimal downstaging of the tumor to either facilitate surgery or potentially a non-operative approach. There are potential downsides of total neoadjuvant therapy. If patients progress with TNT, there could potentially lead to a missed window of opportunity. It requires accurate pre-treatment staging. And then another one is that could potentially overtreat patients because you're not getting pathologic staging. So back to the slide before about the 6 months of chemotherapy, if you have upstaged the patient based on their MRI, then they could potentially get more treatment than would be determined if they got surgery and then chemotherapy after. Next slide. So the Rapido trial, this was presented at ASCO in 2020. So this was a randomized trial comparing the standard that we had talked about, long course chemoradiation, surgery, and adjuvant chemotherapy with short course radiation, which is over 1 week, followed by 18 weeks of chemotherapy and then surgery. The inclusion criteria are listed on the right, but basically these were high-risk patients staged by MRI with one of the 5 features on the right. Next slide. So the primary endpoint was a composite endpoint called disease-related treatment failure. This included distant mets, local regional failure, a new primary colorectal cancer, or treatment-related death. Next slide. So this slide is just to show that this was a large study of almost 1,000 patients, 920 patients who were split between the standard and experimental arms, randomized 1-to-1. Next slide. So the slide or the table on the left shows that the surgical complications were not increased with the addition of chemotherapy prior to surgery. And the table on the right shows that the rate of R0 resection was similar with both strategies, but perhaps not surprisingly, the pathologic complete response rate was higher with the addition of chemotherapy prior to surgery. Next slide. And these are slides of the outcomes of the trial. So the disease-related treatment failure composite primary endpoint was improved with the experimental arm. And that was primarily driven by lower rates of distant mets, as you can see on the top right. There was no difference in local regional failure or overall survival between the two arms. Next slide. So the messages from, or the stay-at-home messages from the presentation were that short course radiation, Capox, and followed by surgery led to a lower disease-related treatment failure rate, primarily driven by a lower distant met rate. The pathologic complete response rate doubled from 14 to 28%. There was no difference in overall survival, no unexpected toxicities, and no differences in surgery, post-operative complications, and quality of life between the two arms. Next slide. And I think Dr. Soares was going to talk about the study.
Yeah, just to bring awareness of different TNT strategies, I just want to highlight that another trial that was recently presented was the Prodigy 23 study, which is essentially the approach of using total neoadjuvant therapy with modified FOLFIRINOX in these patients. And this trial was compared against perioperative chemoradiation for patients with locally advanced rectal cancer. And essentially in terms of the eligibility criteria, patients had to have T3 or T4 tumors. They were also stratified whether they have positive lymph nodes versus no, and the location of the tumor in terms of centimeters from the ulnar verge, with the cutoff being plus or minus 5 centimeters. And again, they were randomized to receive the long course chemo radiation with 50 gray, then TME surgery, followed by chemotherapy to complete the whole perioperative treatment, or they were randomized to receive the modified FOLFIRINOX for 6 cycles or about 3 months, then the chemo radiation with 50 gray and capecitabine, waiting about 7 to 8 weeks, receiving surgery, and then completing, finishing up the chemotherapy with FOLFOX or capecitabine. Next slide, please. And here is what we see. We can see that with the TNT approach, which was studying 213 patients, you have a significant higher number of tumor regressions with a lot of pathological complete responses. But that comes up with some adverse events. Adverse events. I have to mention that we always been concerned about having a lot of chemotherapy up front be associated with worsening toxicity, and we can see here that's not necessarily the case for many of the concerning side adverse events that we have. And you can see here neutropenia, lymphopenia, and peripheral neuropathy. When we look at that before, it was always less than with the chemoradiation group. In terms of disease-free survival, and we're talking about where's disease-free survival, we can compare, and you can clearly see that it was favorable with the TNT approach, and metastatic-free disease survival as well was favorable with the TNT approach. And I just want to highlight that for that about 54% of the patients were relapse-free, with relapse were alive at the time of this analysis. So that might be something to keep in the pocket for patients that you are concerned with upfront staging, that you might feel they might benefit from a more intense induction treatment, if I may. Next slide. I'll give back to Dr. Sanford.
Right. So with the presentation of these studies last year, there were a lot of questions about how to optimally treat locally advanced rectal cancer patients. Should we omit surgery? Should we intensify chemotherapy? Should we omit radiation? So ASTRO, which is the American Society of Radiation Oncology, came up with guidelines, and I highlighted a couple of points here. So one is when can radiation be omitted? And this was actually conditionally recommended for stage 2 patients at lower risk of local regional recurrence, with lower risk defined as clinical T3A or B, a high rectal tumor greater than 10 cms from the anal verge, with a circumferential resection margin of at least 2 millimeters and no extramural vascular invasion. And this was based on a couple of studies showing basically a very low local failure rate without radiation for tumors that fit this criteria. Next slide. And then, who qualifies for total neoadjuvant therapy? So basically, among patients requiring neoadjuvant therapy is the patient at risk of increased recurrence. And these were the criteria felt to portend high risk. So T3 tumors less than 5 cm from the anal verge, so distal tumors, less than 2 millimeters circumferential resection margin, a T4 tumor or clinical N2 disease, or the presence of EMVI. So basically the opposite from the last slide. But these were patients where it was felt that they could benefit from total neoadjuvant therapy. Next slide.
So the case continues, and the patient likes to proceed with TNT with short course radiation, followed by 6 cycles of FOLFOX. Patient goes to surgery, and the final PET is at T2 and 0 with free margins. Next, go to the next slide.
Okay.
So we're going to talk about surgery next. So I have to say that the thing that I find very interesting with all of this is that there's so many different ways to approach these patients. But I think that as we talk a little bit about our surgical options, we're also going to talk a little bit about why it's so important to make sure that your staging is accurate and up to date. So let's move on to the surgical options next.
And in discussing total neoadjuvant therapy, one other advantage of it from a surgical standpoint that I want to mention is all of these patients that have been radiated and are getting rectal cancer surgery will always have a temporary diverting loop ileostomy. And with traditional treatment, they keep that ileostomy until they've completed their 4 months of adjuvant chemotherapy. So they have to have it for a significant period of time. Where if they got all of their therapy up front and aren't going to require any chemotherapy, we can often close the ostomies at 6 weeks. So that means that they keep their ostomies for a shorter period of time, which obviously they appreciate. But so when we talk about surgery for rectal cancer, it has changed a lot in recent years. Meaning the late of the last century. But traditional rectal cancer surgery was associated with very high rates of local recurrence, as you see here, pretty much always double digits. And what's changed is that what we call total mesorectal excision has been the standard. Next slide. And so what does that mean when we say total mesorectal excision? So obviously we have the rectum, and then the rectum is surrounded by this envelope that contains the fatty tissue, that contains the vasculature, as well as the lymph nodes. And current standards for rectal cancer surgery require that you remove all of that tissue in one envelope, and that you don't violate the mesorectal fascia. Next slide. And we're going to start that video. And so this is what that looks like. What you're looking at here. So that kind of white filmy tissue is the plane that you want to do your dissection in. Above that, the yellow tissue, that's the actual mesorectum. And so when you're operating, you want to make sure that that yellow tissue stays intact. And when it's done, there should be a nice shiny surface around it that represents your mesorectal fascia. And so here, and looking at this video, we're coming down the right side of the rectum and dissecting the mesorectum out of the pelvis. And then here we're anterior to the rectum. This is the anterior peritoneal reflection, which is an important landmark that we look at when we're reviewing our MRIs. So we've opened up the anterior peritoneal reflection, and at the top of the screen there, you're seeing the prostate. So this is obviously a man, and we're dissecting the prostate off of the rectum. And again, you see that nice filmy plane that we continue in. And here we're all the way down at the level of the pelvic floor. So you're actually seeing the muscles of the pelvic floor, and we're taking those muscles off of the rectum so that we're able to transect the rectum distally down in that space. Next slide. And so this is what it should look like. Thank you. This is what it should look like. And our pathologists actually grade the quality of our specimens. So once we send the rectum to the pathologist, they're going to grade the quality of our mesorectal dissection. And what you see here is a significant amount of bulk around the rectum. You see the nice shiny surface of the mesorectum without any violations of your mesorectal fascia. And that's the goal in rectal cancer surgery. Next slide. And this is some data showing why that's important. So if from this study, if your mesorectal envelope was intact, your rate of local recurrence is only 4%. But if you violated the mesorectum, it goes up to 7%. And if your surgery has gone all the way into the muscularis of the rectum, then your rate of local recurrence increases all the way to 13%. Next slide. So how do we measure quality in rectal cancer surgery? Obviously, the number one thing that we're all concerned about is survival. Next quality measure, secondary survival, would be local recurrence, your rates of local recurrence. Those are things that often we don't see over time. So there are other sort of surrogate oncologic measures that we look at, which is, again, the quality of your total mesorectal excision, as we just discussed, your resection margins, and then you can also look at lymph node yield. Next slide. One of the questions I'm most often asked, and that's particularly relevant in this case that we're discussing today with a tumor at 3 centimeters, is how low can you go? You know, what is your cutoff for when a person needs an abdominal perineal resection with a permanent colostomy versus a low anterior resection where you can restore continuity? And there is no absolute centimeter measurement. The main determining factor is whether or not there's involvement of the external sphincters. So if tumor is growing into the pelvic floor, into the levators, or into the external sphincters, that means that those need to be resected. And that means they have no chance of continence. And so they're not a candidate for restoration of continuity. So those patients would get an abdominal perineal resection. But as long as there's no invasion of the external sphincters, regardless of how low the tumor is, it can be possible to remove it. Not always the right thing to do, because continence can be greatly affected with a really low resection. But for patients with good continence and that are motivated to avoid a permanent ostomy, you can dissect in the intersphincteric space. So if the external sphincters are not invaded, you can separate the internal sphincters and the external sphincters and divide someone very low. Next slide. And I think if you click that video will play there. And so this is an example of what that looks like for a very low tumor. For those of you not used to seeing videos like this, I apologize for the graphic nature of it. But what you're seeing in this video, obviously we're working from the perineum. The rectum and the mesorectum has already been completely mobilized from an abdominal approach. And then we go down below and essentially transect the rectum distal to the level of the tumor. And we enter that intersphincteric space and work up between the internal and the external sphincter until we've communicated with the abdominal portion of the operation. And then so transanally, we can remove the entire tumor that way, along with the mesorectum. And once we've done that, we essentially just transect the rectum at the level of the anal verge and then do a hand-sewn anastomosis between the colon and the anus. Next slide. And so that's a picture of what this looks like. So the colon has been brought down essentially to the level of the dentate line, and we're doing a hand-sewn anastomosis. Next slide. This is kind of how we see in there. We use this retractor device in order to be able to do the anastomosis in the anal canal. Next slide. And then once that's removed, you can see from the outside, they look essentially normal. The anus looks pretty normal. And then there's anastomosis just, a couple centimeters inside, depending on the level of the tumor. Next slide. One of the other areas that has been somewhat controversial in rectal cancer surgery is should these operations be done via a laparoscopic or robotic approach. And so this is a meta-analysis that looked at using laparoscopy for minimally invasive surgery. This looked at a number of different studies published between 2001 and 2011, and they found that mortality with laparoscopic surgery was only 1% as compared to 2.4% for open, and that overall laparoscopy was associated with less morbidity, less blood loss, and basically better patient outcomes. Next slide. And so based on this, they essentially determined that laparoscopic surgery was more cost-effective and produced better patient outcomes, and they recommended that this become a standard. Next slide. However, there's been some concern as to whether the outcomes that we've seen for colon cancer, whether they apply for rectal cancer as well. And a few years ago, there were actually four large studies going on across the world that were comparing a minimally invasive approach to an open approach. So there was the ACOSOG trial here in the United States, the COLOR trial in Europe, the Korean trial in Asia, and then the a la carte trial in Australia. Again, these were all comparing laparoscopic versus open resections. The COLOR trial and the Korean trial were slightly stronger studies in that they went on over a longer period of time and actually measured survival as well as local recurrence. The ACOSOG and the a la carte trial, at least initially, just looked at kind of surrogate markers, such as the quality of your mesorectal specimen. Next slide. And when we pull the data from all these studies, the different kind of surrogate markers that they looked at were quality of your TME, and across the board, they saw no difference in quality of TME. So there was the TME was complete or nearly complete in about 95% of patients, whether it was lap or open. Next slide. And almost all patients, almost 100%, had negative distal margins, and that was true whether they were laparoscopic or open. Next slide. And while it was not seen in the Korean or the COLOR trials, the ACOSOG trial here in the US and a la carte in Australia did, however, find that there was a higher rate of having a positive circumferential resection margin in the laparoscopic group as compared to the open group. And across, looking at all the trials combined, it's about a 2% higher positive circumferential resection margin. And so this led some people to be concerned, is laparoscopic surgery as good as open surgery? Next slide. However, since that time that those studies were initially published, both ACOSOG and a la carte have now published their longer term survival rates. And both the a la carte trial as well as the ACOSOG trial showed that there was no difference in disease-free survival between the laparoscopic group and the open group. Next slide. So what can we take home from all of that data? Across all four studies, none of them have showed a difference in survival between laparoscopic and open resections. Laparoscopic surgery might be associated with about a 2% higher rate of having a positive circumferential resection margin. However, because it's associated with a 50% reduction in mortality, as well as decreased morbidity and improved short-term outcomes, I think we're quickly moving to where a minimally invasive approach is becoming the standard for rectal cancer surgery. And next slide. So particularly in this patient, what about when there's multi-visceral organ involvement? So we talked about the MRI before, and it is absolutely crucial for surgical planning. We discussed kind of how we use MRIs at our various institutions. We always get one pre-treatment. We use it a little bit more selectively post-treatment, but in patients where you're concerned about multi-visceral organ involvement, I think a post-treatment MRI is very crucial. Number one, you're assessing resectability. Is this tumor actually resectable? You're looking for evidence of extrarectal involvement. What other organs are involved? You're looking at your circumferential resection margin and getting an idea of whether or not that margin is going to be positive if you have to go outside your regular planes of resection. And then, is there invasion of the sphincters? So MRI is very good at telling us that. And as I mentioned earlier, that can often determine whether a patient gets an APR or whether they can be put back together. But when someone has multi-visceral organ involvement, your goal is always to do an en bloc resection. And this may require a multidisciplinary team. For example, in a male with invasion of the prostate, it will usually be urology as well as colorectal surgery in order to remove the rectum, bladder, and prostate as one intact unit. And then those patients would get both a colostomy as well as an ileal conduit. And then in the case of this woman, the uterus would want to come out en bloc with the rectum. There are some cases where it's a little bit questionable as to whether or not it's resectable. And if you're talking about doing a really aggressive resection, such as possibly removing part of the sacrum, you really have to balance what you think their chances of actually having long-term survival are with the consequences of that operation. So in this patient, the surgery that I would recommend would be, we said it was 3 centimeters from the anal verge. We would want to evaluate the MRI and determine whether or not there was invasion of the external sphincters. And so depending on that, she could either receive an LAR or an APR, and that would be done en bloc with the hysterectomy.
So now we're going to move on and transition and talk a little bit about life after treatment. So we're going to focus on some adverse events, sexual health, fertility, especially if patients who are interested in having biological children in the next couple of years, and then some surveillance strategies.
Sure. So as younger patients are getting diagnosed with colorectal cancer, it's increasingly important to talk about side effects after treatment. And I wanted to focus on some sexual side effects after radiation therapy in women. So they're listed to the left. And these can include vaginal dryness, thinning, vaginal stenosis and shortening, dyspareunia or pain with intercourse, vaginal bleeding, and also injury to the bladder or bowel. Radiation can also cause infertility or menopause. And with that, there are several associated psychosocial effects. Next slide. So really the best treatment for vaginal stenosis and shortening is prevention. And the best way to do that is with a vaginal dilator, which basically looks like a tampon. And you can see them to the right. We tell women to use the largest size that is comfortable. So we advise patients to start using a vaginal dilator about 4 to 6 weeks after pelvic radiotherapy, daily unless sexually active, for about 15 minutes or so at a time. And I tell women that the most critical time to do this is for about a year after treatment. After that, there can be irreversible scar tissue formation. Next slide. So in regards to fertility, I think the most important point, unfortunately, is at the bottom of this slide, which is basically that with doses that we give for pelvic radiotherapy in GI cancers, the risk of infertility is about 100% in women. On the table or on the figure to the right, you can see that the risk of infertility increases as you are older. However, again, because the ovaries are right in the radiation field, there's really it's very difficult to preserve fertility if patients are getting pelvic radiotherapy. Radiotherapy impacts fertility in 3 ways, primarily hormonal dysfunction, ovarian dysfunction, also uterine dysfunction. And there are not a lot of studies, but some showing that pregnancy after radiation for women who are able to get pregnant if they have received lower doses of radiation can be associated with adverse outcomes, including low birth weight, prematurity, perinatal infant mortality. And this is thought to be due to radiation-induced uterine damage. Next slide. I also wanted to point out that chemotherapy can also impact fertility. And on this slide are some of the chemotherapy agents stratified by risk of infertility. Fortunately, the ones used in colorectal cancer are actually lower risk. Next slide. And there are, I don't want to go into too much detail on this slide, but basically there are fertility preservation options for female cancer patients undergoing cytotoxic chemotherapy. Obviously, these take time, especially in women. It's a lot harder than just simply sperm banking, which our male counterparts can do. So there's always sort of a race against time to start treatment versus these also very important fertility considerations. Next slide.
So next, we're going to talk about some surveillance strategies, kind of what to do next and how we do surveillance. And this is something I think there's a lot of discussion and debate on. We see people talk about 3 months, 6 months, a year, really dependent on how, what the stage is, and then also the culture of the institution. Timing of imaging, when to do a colonoscopy, I know is something that's often debated. And then the latest and greatest, talking about ctDNA or circulating tumor DNA. So I'm really curious as we move into this next section, before we talk about it. Have any of you heard about any kind of controversies or when it comes to any of these topics, when you talk about surveillance strategies, anything that you think is done that shouldn't be done, or anything that should be done that isn't being done regularly?
So I'll jump in. I think in terms of timelines of imaging for the first 2 years, I personally do scans every 6 months. And I know that the guidelines, as a matter of fact, the rectal guidelines are just being updated on September. So, they say that we can do 6 to 12 months, and considering, I believe, 6 months class 2A for imaging. But I tend to image in the patients in the first 2 years every every 6 months. Obviously, the colonoscopy is up to a year out. If the patient presents with obstruction, then we should do sooner than that. That has been my practice with my colorectal surgeons, and I think that's where endorsed by the rectal guidelines. I think the most controversial thing is about the circulating tumor DNA. What do we do with that information? I think the jury is out there. There's several trials going on to understand how to incorporate circulating tumor DNA in the strategies, whether the patients had resection or whether they decided to do a watch and wait approach. I have been incorporated really on a case-by-case situation with a lot of discussion and counseling to the patients. And we do have one of the circulating tumor DNA trials open here, so I encourage the patients to participate on that. That's my take. I welcome any other thoughts.
Yeah, so I completely agree with everything that you said. There's really no randomized data on surveillance strategies, which I think makes it tough. It's just sort of consensus opinion. I find that patients would be very anxious if you recommended 12 months follow-up from the end of treatment. So sometimes I'll do a post-op scan in about 3 months and then sort of tailor the follow-up depending on what findings are there. If it's really nothing there, then I agree 6 months is reasonable. But if there is some suspicion of something there that bears watching, then I might do it a little bit more closely.
In terms of circulating tumor DNA, I always defer to my oncologist in terms of when that should be ordered. But I do think it's really interesting, the limited data that there is, and I'm curious to see what we find out in the future. We get CEAs routinely on everybody, but we don't really have any evidence that getting a CEA on anybody affects their outcome in any way. So I'm curious to see if in the future circulating tumor DNA might replace our monitoring of CEAs, but time will tell.
Yeah, and I will say ctDNA, I have a lot of my more educated patients who've done their own research asking about circulating tumor DNA, and I often tell them I'm happy to do it. We don't really know how to intervene based on the results, but it is helpful to have the information, at least to have more information. But yeah, I agree, more to come on that. And I also agree what was mentioned earlier about the 3 versus 6 months versus a year. I often do my first set of imaging 3 months after, especially in somebody who I think is going to be higher risk, or I have a higher concern that maybe we might have understaged them, or that they had any high risk features. So sometimes I do that first scan at the 3-month time mark, and then I move to 6 months after that, just to kind of tailor my approach to each patient based on what they found when they underwent their initial imaging, and then also when they underwent their surgery. So let's talk a little bit about an alternative scenario for this patient. So this patient has now had a complete response from radiation and chemo and wishes to avoid surgery, which I know is also a very hot topic. I had a conversation with a surgeon just yesterday about one of my patients who were trying to discuss whether we should or shouldn't avoid surgery. So we talked about how often to surveil and how. I'm really curious about the conversation regarding whether to do surgery or to not do surgery. I think is a very hot topic that we should probably spend at least a few minutes talking about when we talk about these types of patients. So I'm gonna leave that hanging as a discussion after we talk a little bit more about this case, and then I'm gonna come back to it at the end of this discussion. So let's continue the case. Let's talk about the need for MRI and endoscopy.
Yeah, so, I think talking to my colleagues from colorectal surgery and radiation oncology, we feel that perhaps both strategies are important, and I will welcome Dr. Cannon's thoughts and Dr. Sanford on that.
Yeah, so basically, in putting together this slide, I just wanted to reiterate that to assess response, one needs to both look on MRI and endoscopy. Sometimes there can be discrepancies between the two, especially after pre-treatment, looking at fibrosis versus viable tumor. A lot of times an MRI will, overcall whether or not there is residual tumor, and then on the endoscopy, you'll actually see no residual tumor, but actually sometimes vice versa too. So one really needs both. Sometimes we'll see an MRI after treatment that looks very, very promising, and the patient will be really excited about potentially not going to surgery, but reiterating that they need an endoscopy as well is very important.
And I'm curious, actually, before we move to the next slide, when do you do endoscopy post-operatively? When is that first endoscopy that you all recommend?
You mean post neoadjuvant therapy?
Correct.
Yeah, so that's a really great question. We tend to do one probably, around 6 to 8 weeks after. But anecdotally, we've had patients who've not been able to make their scans or their endoscopy, so they actually wait longer and then they have more response. So then you think, well, why can't we wait longer for more patients? But then obviously you don't want to wait too long without treatment. So I don't know, there's probably a sweet spot, but it's also probably variable by patient. But curious what other folks do.
And I would say, so we're not routinely getting an endoscopy on these patients, to look for a complete response. But if you suspect, you do your rectal exam and you can feel the tumor before and you can't feel it now, if you suspect that they may have had a complete response and think that you might be considering a watch and wait strategy, then they would usually get that endoscopy around the time that they would have had their surgery. So again, yeah, probably 6 to 12 weeks, because we're probably making that decision when we would have been seeing them to plan for surgery. And we use this strategy very sparingly, but when we do, after we've made the decision to pursue a watch and wait, then they'll both get MRIs as well as endoscopy every 3 months.
Great. All right, I'm going to move on because I know we're running short on time.
And I think this slide is just to highlight that some of these tumors will come back. And I think the jury is still out there, but when we think all together, we can probably consider that there is a chance that tumor will grow between 20 to 30%. And Dr. Cano, if you disagree when you're counseling your patients, let me know. Otherwise, we'll jump to the next slide.
Sure. So I'm happy to talk about the OPRA study, which is the organ preservation in rectal adenocarcinoma trial, bled out of Memorial Sloan Kettering, but a multi-institutional trial. So this was a randomized study looking at different total neoadjuvant therapy strategies, either starting with chemotherapy or starting with chemoradiation. And then for patients who have either a complete or near complete response, for them to go a watch and wait strategy. Next slide. So I wanted to discuss the criteria for going on watch and wait on this study. So they actually used 3 things: an endoscopy, a digital rectal exam, and an MRI. In patients who had either a complete response, defined here, or a near complete response, would qualify to not have surgery, versus those with defined no response or partial response would go on to have total mesorectal excision. Next slide. So more on the study schema here. Basically, patients either got chemotherapy first, which is FOLFOX or CAPOX, over 16 to 18 weeks, followed by chemoradiation. This is long course chemoradiation, or the opposite sequence. They had restaging with a DRE, endoscopy, and MRI, and then they were stratified into responders or non-responders who underwent either watch and wait or TME. So the initial results were presented at ASCO last year. And basically, disease-free survival and distant metastasis-free survival, there was no difference between the different strategies. But organ preservation, OP, was improved with starting with chemoradiation. And it was 58% versus 43%. Next slide. And this is showing those results in figure form. So again, there were 359 patients. And again, this figure to the right is showing that TME-free survival was improved in patients who got chemoradiation first. Next slide. So at ASCO this year, they presented a slightly different analysis where they looked at looked at outcomes when stratified not by what type of treatment sequence you had, but rather if you had a clinical complete response, CCR, a near complete response, NCR, or an incomplete clinical response. And they showed, perhaps not surprisingly, that the best outcomes were in patients who had a clinical complete response in terms of organ preservation. It was 79%. Next slide.
All right, so the case continues. The patient ended up going for surgery. There was just an alternative scenario. 4 years passes, and now, unfortunately, when she was doing her annual scans, she has liver mets. As you can see here, I'm not a radiologist, but I just want to point that she had bilobar liver mets. There was biopsy proven adenocarcinoma was consistent with colorectal origin. At that time, NGS was ordered. They came back as a microsatellite stable disease, wild-type RAS, wild-type BRAF, and a HER2 new overexpress and 3+ on IHC. For the sake of the discussion, and I know that depending on the place that we work can be a little bit different in how aggressive one should consider liver resections, let's assume that this patient was deemed non-resectable. Next slide. So now this patient is living with metastatic colorectal cancer, and there are several different choices that one should take into account, including the patient characteristics of the patient that you're seeing in front of you, age, comorbidities, performance status, prior lines of chemotherapy, and what is important to the patient in terms of quality of life and toxicity. And I don't want to expand too much into that, but we know that, in patients that have considered bulk disease and a good performance status, we have data that shows that FOLFOXIRI improve overall survival in these patients that should be considered. I think we haven't necessarily incorporated that for every single patient because we know that FOLFOXIRI is a challenging treatment, and sometimes take into account the patient quality of life that is not something that is relevant to the patient. So this patient initially received the first-line treatment with FOLFOX and a biological here. In this case was bevacizumab. And then go to the next slide. Eventually, this patient progresses on first or second-line treatments for metastatic disease. And we saw that this patient had a HER2 overexpressed tumor with a T+ by IHC. And we know that HER2 overexpression is present in about 5% of metastatic colorectal cancer, in particular in the left side and rectum. And the reason why I want to bring this up, because there is so much excitement in terms of HER2 therapies for colorectal cancer. And prior to this, we have historical data that shows that HER2 positive colorectal tumors have worse prognosis and they will drive less benefit from anti-EGFR, right? So the debate whether or not should be considered anti-EGFR therapy up front, if you take into the context the HER2 is probably not the ideal situation. That's why FOLFOX plus bevacizumab was chosen to this patient. Next slide is first line. So I wanted to just quickly bring it up because we're going out of time about the study. There was a phase 2 study that was presented recently on ASCO with trastuzumab deruxtecan in patients with HER2 expressing metastatic colon cancer, which is the Destiny CRC01. Next slide. This trial enrolled patients that had more than 2 lines of therapy for metastatic disease. Many of these patients had a prior HER2 therapy. The patients prior to proceeding to treatment had to have a biopsy to confirm that they actually continue to express HER2, because we know from the gastric literature that they might lose it, but that was not the case in this study. Majority of the patients kept their HER2 expression, and they were treated with this drug, which is IV every 3 weeks. And the folks that take care of breast cancer know this medication extremely well. And we saw that patients had confirmed overall response rate is about 42% of the cases, as you can see here, with most of them being partial responses. Next slide. These are the diagram that shows the volume of responses, and you can see that some patients had prior HER2 therapy, some patients did not, and it's quite impressive force plot. Next slide. Again, shrinkage of these patients over time, very impressive responses that can be seen. Next slide. And in summary, just to highlight that metastatic colorectal is extremely heterogeneous disease, and therapy should be tailored to the patient that is in front of you. I would encourage everybody to really order NGS on all your metastatic patients up front, because that might help you to decide therapies just ordering RAS or BRAF or BRAF might not tell you the whole story, particularly because we know the HER2 positive patients might not respond well to anti-EGFR. So please consider ordering NGS upfront to all your metastatic patients, in addition to MSI status, of course. Next slide. So the take-home message, I think, that we no longer see colorectal cancer or as a single disease. There are many subgroups. Profiling is very important. Take into account some of the key targetable biomarkers that we have, including MSI high, BRAF, RAS, HER2-neu, and TRAC. And we keep enrolling clinical trials, and hopefully we can keep moving the field forward. That's what I have. Thank you.
So we got in just under the wire. I know we had plans for a robust discussion, but we had such great content from our panelists today that we're going to have to take the discussion to the Q&A. So I hope people have been asking questions and we will have been responding them in the chat. Thank you so much for joining us for this phenomenal panel on GI oncology. And I want to thank our panelists. I want to thank all of you for attending. And I want to thank Total Health Conferencing for putting on this phenomenal conference and this great presentation today. Have a great rest of your day, everyone.